Okay, I am going to turn this over to Carrie Bennett for the Revenue Integrity Panel. This panel is sponsored by Georgia Hospital Association, but there is no one from the Georgia Hospital Association present, I don't believe, because they are on a COVID travel ban. So we very much appreciate the Georgia Hospital Association's sponsorship of this panel, and I'm going to turn it over to Carrie. Oh, no, yeah, you can have some. No. 5 more minutes. I'm like, these people are sick of hearing about me. They don't want me to talk for 5 more minutes. No.
Okay, hey y'all. I'm super excited to be up here this evening with all these wonderful panelists and Bobby, who's remote with us this evening. I've been having a little competition going with Ashley Hill because I think I have the best panel and she thinks she has the best panel. So you guys are going to have to give us a little feedback evaluation on who has the best panel at the end of all of this. I think your survey results will reflect that I have the best panel, but we'll see. So for now, I'm going to let each of my panelists take a moment to introduce themselves. I'll let Bobby start since he's remote up on the screen in the air, and then I'll go from Liz, Shanen, and then Jennifer. So go ahead, Bobby.
Thanks, Carrie. Can you hear me okay?
A little louder.
Can you hear me?
We're working on it. Okay, try again.
How's that?
Great.
Good?
Yes.
Can he hear you?
You
sound good.
Sorry, I'm having trouble. Can someone just confirm you can hear me?
Correct.
Okay, thank you. I appreciate you accommodating me remotely. If I knew I'd be plastered up on the big screen, I probably would have shown up in person. But thanks for having me. My name is Bobby Martello. I am the Director of Patient Accounting for Professional Billing at Children's Healthcare of Atlanta. I've been here in my role for about 4 years now. In this role, primarily I have responsibility over all insurance, accounts receivable, collections, denials management. I also have responsibility of the cash applications team for both hospital and professional billing. And then what's most relevant to this panel, I recently inherited, and I'm also in the process of kind of expanding the scope of a professional revenue integrity team, which is something new to our organization. And within the context of that team, I'll have responsibility over things like charge capture, charge reconciliation, charge edits, all things kind of professional pre-AR. Prior to Children's, I spent most of my career in consulting, most recently at FTI Consulting and the Health Solutions practice there. And prior to that at Triage Consulting Group, which is now a part of CloudMed. So thanks for having me.
Can it come?
Yeah.
Thank you. Okay. Can you guys hear me? Yes. Hi, everyone. Hope everybody is doing well. I am Elizabeth Battle. You can officially call me Liz. I am the charge capture. I'm sorry. I always get it wrong because it's so long. I am the charge coding and revenue management director at Wellstar. Currently, I have I'm kind of a bit of a jack of all trades because we're in transitions, but I'm over our centralized coding team. They're called charge capture specialists, and then I have a dotted line to our practices which have decentralized coders. I am a liaison for physician training, so I talk to compliance and connect them to the physicians that need different training and different aspects and different specialties. I am also over fee schedules, so we do everything as it pertains to the charge master DM as far as like the PV side and putting in the fees and getting proxy codes and things of that nature. So overall, kind of the whole gambit of the revenue cycle for me. I have about 17 years of revenue cycle experience with about 13 years at Emory, managing and coding and doing centralization and things of that nature. I have 2 years at Piedmont and about 1 year and 6 months at Wellstar. And so my goal right now is like to centralize and get people to understand the importance of coding from a PB perspective.
Good afternoon, everyone. Can you guys hear me? Okay, so my name is Shanen Hollingshead, and I currently serve as the Assistant Director of Patient Financial Services at the Emory Clinic. In my role, I oversee revenue cycle operations and provide revenue cycle support from a coding and billing standpoint to about 12 divisions at the clinic. It covers about 30 locations and supports about 600 plus providers, so it's always an exciting time. I've been at Emory for about 10 years now. I am a millennial, so it's always a surprise when people hear that, but I have been at Emory for 10 years, and I've been leading revenue cycle teams for about 8 years at Emory. So during that time, I've had the opportunity to work with various leaders in the revenue cycle, so I'm excited to be here and looking forward to the conversation.
These are two tough acts to follow, so I'll do my best. Hello, my name is Jennifer Burchell. I'm the Director of Revenue Integrity here in town at St. Joseph's Candler. This is my 3rd year here. I moved from Ohio, so I'm sorry if you don't like me, but OH if you do. All right, there we go. I have been in healthcare for 20 years, 21 maybe, 21, maybe 22. I'm not sure. You stop counting kind of like birthdays maybe till you hit certain marks. I don't know. So I've been everywhere from scanning medical records to QCing, working with physicians with release of information, started in the coding, and then I moved into the charge master, and that's where I really found what I like to do because I'm a financial person, but I get to talk to a lot of people in the clinical departments, so I really appreciate the interaction, especially at the facilities here. There's a lot of interaction with a smaller hospital, so I've been really enjoying my experience so far here in Savannah.
Okay, so I told you I had the best panel. It's pretty obvious, obviously. Okay, so as they all mentioned, we've been really focused on middle revenue cycle and revenue integrity for the purposes of this panel. And the way this will kind of be structured is we've talked about which questions folks feel most excited to answer. So I'll throw some questions various people's ways based on our conversations. I think the team did a great job about talking about how they're organized and structured. So the first question that I will ask Liz and Jennifer and Bobby, and we can go in that order, is what their biggest challenges are in the middle revenue cycle right now.
So my biggest challenges right now is, so I come from a role where everybody is used to being remote. And so at Wellstar, we kind of had like a mixed bag of people being on site and remote. And so when everybody went remote, it was kind of a big deal for the people who are not used to being remote. So trying to do a balancing act of making sure that you understand the folks that are not remote and what they need and different things as far as like productivity and things of that nature has been a big deal, along with the telehealth portion of it. So it was a different role as far as like personnel, them understanding what we needed to go through as far as the COVID crisis from a billing aspect, making sure they're remote and kind of like doing a fine balance of that to make sure they understood the whole concept of everything with the remote world as it pertained to COVID and all of those aspects.
I'll go next. Okay. Two big things come to mind for me. Number one, charge reconciliation. Balancing that relationship with the clinical departments and helping them understand and maintain their responsibility of checking their revenue all the time, making sure that they're not out of balance, especially if they wait 3 months and then they call me and say, something's going on with my revenue. Can we take the next 8 hours and figure it out? We don't always have time for that. So it's nice when people are able to keep up with that. The other one, thankfully and fortunately and a little sometimes unfortunately, I call it growing pains. So when your organization starts to grow, you're kind of getting too big for maybe what you currently have. So I'm actually, I've created more staff for my department because we are getting bigger and we are seeing a lot more of the financial importance in our culture and in our area with the new sites. We have some new oncology sites that are coming up, and our physician side is still growing, and we're working with them if we have things that have to do with the technical piece of those charges. So,
Bobby, anything you would add to that?
Yeah, I would just echo a few of the statements already made. For me, the one unique aspect, given that I'm in the process of kind of forming this new team, really the organizational structure component of that is certainly a monumental effort. Historically, most aspects of the professional revenue integrity side or middle revenue cycle have been fairly decentralized. So we're working to centralize what we can, really define roles and responsibilities as it pertains to reconciliation. Who owns it? Is it at the practice, or is it going to be centralized? The only other thing I would add is really staffing and keeping up with volumes. What's going on with especially in the pediatric space with RSV, COVID, keeping up with getting our coding completed, getting charges dropped as we try to balance staffing with our expanding volumes.
That leads me on to my next question. So thanks for teeing that up, Bobby. I know this whole group probably has some comments on this, and I know we have a lot of staffing friends in the room who might be curious about your answers to this question. But what kinds of challenges are you facing as staffing goes in your organizations, and what kind of tools and help do you guys need from that perspective?
Yeah, so from a staffing standpoint, obviously with the pandemic, many of our groups had either really high volumes or really low volumes, and we've kind of had to do some shifting. So from a clinical perspective, as well as from an administrative perspective, we saw a lot of cross coverage happening. In addition to the cross coverage, we definitely leaned on vendor support. So we were fortunate at Emory to already have those vendor relationships established and able to reach out to them and provide support from a coding standpoint, from a claim edit representative standpoint, utilizing those vendors, and also shifting our coders and shifting our physicians and APPs as needed to the areas that had a lot of volume was kind of our approach to handling it.
For me, so when COVID first hit, you had this deep lull and nobody knew what they were going to do, and we didn't have much work for the staff. And then all of a sudden that picked up, and then you had this influx of work due to telehealth. So basically for me, the biggest challenge was making sure that you had staff coverage for that volume. We all know that we're going through the great resignation. So people are right now testing the water. So these folks that you knew that haven't moved in 10, 15 years, now they're going like, oh, I'm going across the street because they're offering me $2 more. So a lot of things that I have been challenged with that I'm kind of doing a good balance act, if I grade it myself, is finding talent, because once those really robust revenue cycle billers, coders, and things, once they move, it's kind of hard to replace them. And then there's a trust factor. You want to make sure you're finding those right people who are really dedicated to what they do. And it's kind of, in this new world, people aren't as dedicated as they were 10 or 15 years ago. So my biggest challenge is finding people who want to, one, stay somewhere, they have quality work, and they're dedicated to the work and not just looking for $2. I had someone who moved who called me back and said, can I come back? And I was like, oh, it ain't so green out there, huh? So those have been the biggest challenge, finding that person that has that quality, that investigative nature, and just like really cares about working and keeping staffed in that nature, because the volumes right now are really crazy, and we're really in a lull of having FTEs and folks to work that volume.
Bobby, he left us.
Sure, yeah.
Bobby, are you there?
Again,
Okay.
yeah, can you hear me?
There you are.
Yep.
Okay.
Sorry, I think there's only audio on my side if you're speaking into a mic, so I appreciate it. Yeah, really very similar story at Children's. We had a lot of natural attrition last year, and so then, as everyone has experienced, the volumes came back much more rapidly than we could hire. So we leveraged contract relationships we had with agencies, and then really we're just very, very aggressive internally, even working with vendors to hire full-time folks. And it really did kind of force us to take a hard look, a market review, and just making sure that we're remaining competitive in the market, because what we were seeing out there was pretty wild. I think others may share that same perspective. But yeah, we saw kind of a shift around the middle of this year, thankfully, and we're able to start to actually get some traction in the recruiting space. And so we've made a lot of progress, but that's definitely been probably my top priority for the last, 10 plus months.
Thanks, Bobby. And so along those same lines, what are the other types of vendor partnerships or other types of initiatives besides the ones already mentioned that you guys are looking at right now? I know there's never a shortage of initiatives and things changing in your worlds, but anything else from a charge capture revenue integrity perspective you guys have on the docket right now?
For me, for vendor relationships is just temp staffing agencies that can give me good coders, and just looking for things like stuff that can help me within the system, kind of like reduce the volume, not necessarily towards a CAC type of thing, like a computer assistant guidance or computer assistant coding, but more so of like something that can scrub claims better to assist the coders and kind of make it where you can do straight to bill. And so you can reduce the volumes and reduce the FTEs needed. So those are the kind of things that I'm working on and that I'm looking for.
Do I have any Craneware folks here today? Where? Oh, hello. You're my vendor. Hello. We use Craneware for our ChargeMaster resources. So Craneware has a suite, and they're not paying me to tell you this, but they do have things like pharmacy, supplies, ChargeMaster toolkit, and we have all three of those tools that we're using. And they have another thing called Claims Informatics. It takes your 837s and runs the information through to see if you're missing any charges that you might have missed. An ultrasound guidance charge that wouldn't normally hit an edit, or missing completely a procedure charge that was done, but it was captured through the query within that software. So we're very good friends.
Yeah, so for Emory, we actually have several vendors that we use from a charge capture standpoint. Just to name a few, we use Ingenious Med. So for those of you who are not familiar, our physicians are entering charges on their phones, on their laptops, coming out of the rooms with the patients, and so that does help us capture a lot of those charges quickly. We also use CodeWrite for our imaging-based services, and then now we're moving towards Epic, and so we'll see a lot of our vendors, those relationships transition throughout the next few years. But as it stands now, those are some of the vendors that we use from a charge capture standpoint.
Okay, Bobby, I'm going to skip you on that one because I want to move on to a question that comes kind of on the heels of what I heard you guys saying in this, and it's at the end of our question list. So sorry, I'm jumping into the middle. But, it sounds like there maybe are some different strategies used from the hospital perspective versus the physician perspective. So I'd be curious to hear how you guys partner with your hospital counterparts, or if possible, and vice versa for you, your physician revenue cycle counterparts, to make sure that everything is as streamlined and sustainable as possible.
Would you like me to go? Bobby, would you like to go first?
Sure. Yeah, so that's a good question. We have some overlap, but currently at least quite a different structure on the professional side versus the hospital side. And frankly, what I'm working to build out on the professional side is largely something that mimics, at least structurally, what we have on the hospital side. But naturally, I think, like is the case, as is the case in a lot of organizations, the hospital middle revenue cycle is a lot more centralized. We do have a revenue integrity team that manages the CDM. That is system wide, so they manage. We're on Epic, so they manage all EAP or CPT requests, CDM fee schedules throughout the system, professional and hospital. And then we have a centralized coding team that supports both hospital and professional. So that structure is very helpful and is one that I like. That coding team on the professional side supports primarily procedures, radiology, interventional radiology. And then on the professional side, things from there become a lot more decentralized. We have provider enter charges, and then kind of a practice management structure. So we do certainly collaborate across both sides, but I think there's opportunity to do more of that, and that's what I'm working towards.
Yeah, so for us, I would say that historically, our hospital services and our physician services have not been as close as they are now. With our transition to Epic, and now with both of our groups being under one leader, we see that a lot of the decisions are being made with both entities being considered. And so some synergy is being realized in billing, patient experience, and also from a coding perspective. Long are the days where our coding team on the hospital side would be educating the physician on the topic, and then our physician team would be educating the physician. Now those teams are coming together on new services that are coming up and emerging, and making sure we're giving one message. So I think we've seen a lot of improvement in terms of both of our groups working together, and it's going to continue as we move into Epic.
So I think that's the one thing I can say, well, not the one thing, there are many things that WellStar does well. So every Wednesday we have what is called the Organizational Change Control Committee, our OCC, where all HP, PB, leaders get together, and we pretty much come together, and we have a group of folks that, well, we have a speaker that will come in, and they will have an idea of something that they want to change or put in a system, or construct an Epic or an idea. And so we all get together, that person gives their idea, and we all elaborate and comment on what's going on from a PB and a HB perspective. So we do very well in staying consistent and knowing what each sides are doing, sometimes a little too much, because when the COVID MAB infusions came along, we were both confused because we were doing two different things from the HB-PB perspective, but it was great because I got to see how they were constructing all of the billing on that side, and then when it was my turn to do it, it was kind of seamless for me because I had heard all of the ebbs and flows that they were having on the other side. So I can say we are very congruent and consistent with being very together on the HB-PB side, and it's a great model. We talk all the time. I had to present this morning. My OCC passed. So we're really good at staying connected and being in each other's business, so to speak. So that's a pretty good relationship we have at WellStar.
So I love that topic, and I love this group's feedback on that, because it's something that, you know, I've kind of seen. I've worked on both the hospital and physician side, and I've seen through the transition into the more Epic model of things, you know, everybody's kind of having to come together more. And I think probably for those vendors in the room, you've been asked now to RFP or RFI on both sides of the business for certain service lines rather than just one or the other. And so it's good for us to recognize, especially as a physician, revenue share of a whole health system's finances grows. We need to pay attention to that just as much as, you know, we're paying attention to the acute side. So that's been a key learning for us as a business ourselves. Okay, so along those lines as well, how are you handling all the changes related to COVID and the PHE? One of the topics that came up was credentialing different types of providers in different types of settings, or different, you know, billing changes. So I'd love to hear. I know some of y'all have seen some of that. If anybody wants to start.
Liz has a.
Liz is doing it. Yep, she's
I'm
ready.
sorry, I'm always ready.
Go ahead.
Well, it's been a very, very colorful road with COVID. We've had some good times and some bads. We've crashed, we've burned, but we've one of the great things that we did was we centralized all of the encounters that were for our virtual visits. So that was really, really helpful. So what we did was we got together in the beginning, funneled everything into a work queue, had a subset of coders who looked at it, and as the changes were coming quick and fast, we were able to take this centralized group of people, train them very quickly so they can get a lot of things in and out really quickly. So it's been a challenge because, as you all know, something changes in the billing with coding with COVID every 5 minutes. So I can't say that we've had a lot of successes. We've had to go back to the drawing board on a couple of things, you know, and redo some things and rebuild some things. But overall, I think we've caught a lot of things in the beginning, and that's been very helpful with our centralized work queue and the communication chain that we have. So things have broken, things have been fixed, and all in all, I think we've done pretty good through the COVID barriers that we faced.
Yeah, so I have to say that I think our team at Emory did a really good job in terms of transitioning with the COVID. One of the things that I am happy to see, and I know we talk about siloed situations and how they impact our ability to be efficient, but the specialization that we have at Emory with the managed care, with the compliance, with the coding education departments, they were allowing us to really get a lot of information. They were feeding us information regarding these updates, and we were able to kind of come together and make some strategic decisions about how to handle changes in telemedicine. We had a group that was literally dedicated to telemedicine, and they pulled all of our administrators, all of our physicians. We had leadership on that group that met at least twice a week when the pandemic first started, to make sure that our physicians were aware of what was required with documentation, to make sure our schedules were set up, to make sure that we had the proper edits in the system that were in place. Obviously, there were some hiccups along the way, but I think that specialization really helped us with making sure we got the data and the information to our teams pretty quickly.
Bobby?
Sure, thank you. Yeah, very similar experience to what we've heard already, with telemedicine really being the priority. I think we did a really good job between our clinicians, between our practice management folks, our patient access folks, standing up a telemedicine program. We had some telemedicine utilization historically, but of course nothing like what we experienced with COVID. And then really myself and colleagues in managed care and others really taking a deep dive into the regulations, the various payer policies, of course, what DCH was allowing, to build that out, and just having that open line of communication back with all of our access contacts along with the clinicians, so we were on the same page in terms of what was allowed, what would actually be reimbursable in pretty short order. So yeah, that was definitely a mad scramble, but I think we did a pretty good job there.
Okay, I'm throwing this next one to Jennifer because she's been so kind to keep handing me the microphone back, and anybody else who wants to jump in afterwards. So we talked a little bit about how we're using data and analytics and just some of the things available to us to make sure we're capturing our charges and getting what we need to. So Jennifer, I'd love to hear how you guys are using that.
Excuse me. Savannah, allergies here, excuse me. So we have a couple of ways that we try to use the data that we have. We have Meditech. So we have some revenue and usage reports out of our database that we pull and have the responsibility of the department's review as well. We have account checks that occur at the beginning, right after charges are entered, close to when the coding starts to come into play, so that we can capture any missed charges or anything that might edit down the road. We have created a report that looks at anything that's really high dollar or high units. So if there's a pharmacy charge that's crazy, $2 million for one unit, something's wrong with it, so we catch it before it actually goes out. We've been working with a vendor to do a lot more of the charge usage and reporting, so that we can have an updated, use on a more consistent basis along with those other reports.
Yeah, so I actually started my journey at Emory as an analyst, and my role was literally to go throughout the major checkpoints of the revenue cycle, learn them as fast as I could, and then try to find areas of opportunity to implement solutions. And so at a very, very early stage, I was learning to use the data to try to help us with making decisions. When I came into the medicine team that I currently oversee now, there are a couple of questions that I wanted to make sure we addressed. Number one, are we capturing all of the charges? And the team would obviously say, yes, of course we're capturing all of the charges. Are you sure we're capturing all of the charges? Yeah, we've been doing this for 10 years. This is how we do it. We're capturing all of the charges. How do you know you're capturing all of the charges. And that's when really people started to think, how do we know that we're capturing all of the charges? For those clinic-based services that are scheduled, it was easy. Is there a scheduled visit with a matching bill? But then you have those unscheduled visits in the hospital that were the areas of opportunity. And so our team went in and started to look at the data to try to identify ways to make sure that we could capture those unscheduled visits and confirm that they were being captured. And so that was one of the ways that we used the data. And then once we were confirming that the data was captured, the second question is the data accurate? Are we sending out the correct claims, right? And so part of one of the transitions that we had on our team was we had a lot of post-bill auditors. Auditors would go in, audit the physician's documentation, see what was wrong, charge correct it, send a refund, go back to the physician and do some type of education on a charge that they submitted 4 months ago, right? And the physician doesn't even remember the charge. So one of the things that we did is we looked at that data and said, well, let's pull people to do some pre-bill review, right? And give some physicians some real-time education. So that was part of how we used the data to make sure that the data was accurate. And we also, the charges were accurate, and we also used it to add additional bill edits into the system. And then the third thing that we did was we got the correct charge, but is the charge mature enough to go to the payers? And this is one of the things that the data showed us, is that faster does not always mean better, right? Just because you can get that charge out day one does not mean you're going to get paid anytime soon. Actually, it probably may mean that you're going to get paid later. It may take you more 90 days now instead of 30 days. And so we looked at the data to see that, you know, there were some charges, especially with services that are in the hospital, right? The hospital has their own time of getting the utilization review complete, determining the patient status, getting the authorization. But if we're on the PB side and we're sending that charge out on day one and the patient status changes, then so does the code, right? So we also had to look at the data to kind of get an idea of how long should we really be holding these charges to make sure that it's fully matured so that when it goes out the door, we're not getting these denials. And so that was some of the things that we did to make some intentional holds on services like E&Ms to ensure that when they got out of the door the first time, they got paid. Those are just a couple of items.
So it's a good thing and a bad thing that my whole team over there is a team full of analysts, and I'm not, and I'm always trying to get away from them. So what don't we use analytics for? So let me just run the list. If you think it, if Adam can think it, we're doing the analytics for it. When we first started the new 2021 E&Ms, Adam ran analytics to see how those RVUs were going to change from previous to now, to see if we needed to change our comp models for our providers and things of that nature, and it made us decide to stay static until we could see like how it really worked. And so we decided to push the comp model back because the analytics showed that we may have a big loss in that. So we're going to trend that out, and so Adam is heading that up. On the denials front, Ashley is always looking and seeing what's going on as far as the trends, what is getting paid, what's not. And so we have like a very streamlined communication of where is the kink in the chain as far as like what's denying. And so we use analytics to see like the trends as far as like what has broken, how it has broken, what do we need to fix, and those things oftentimes culminate into us going to OCC to make these big ticket items to put in Epic so we can bring about a change in how we bill and code things. The third thing, because I can go on and on and on and on.
Maybe a loaded question, huh?
The other biggest thing is we have a daily report that's ran for us of our clinic visits, so we can look at it at a glance to see like what our volumes are for our telehealth virtual visits. Is it in a lull? Is it high? Is there something that's concerning? Do we need to look at something? Do we need to hone in on if a provider is billing incorrectly? Doing that helped us find this big issue once where we had a whole bunch of neuro providers who were incorrectly selecting their visit types. So we use analytics all the time in our day-to-day. We've found some big finds, we've had some big wins, and it's continuing on throughout the year. So analytics, everything.
I like that. What about you, Bobby? Anything to add?
Yeah, just briefly, I'd say generally speaking, we rely pretty heavily at Children's on an external data tool, but I will say for those of you on Epic, I've been rather impressed with Epic's professional revenue integrity dashboard. I think it's relatively new, but the key metrics that I'm really keeping a close eye on right now, which are provided by that dashboard, are pre-AR days, charge lag, and so that's something we're using. And then in addition to that, we have built out over the years pretty robust reconciliation program through a variety of reports, both within Epic and external. I think what we're working on now is looking more closely at Epic's professional or PB revenue guardian checks. In my hospital days, Epic released those many years ago, and we rely on those pretty heavily here at Children's. On the hospital side, I think the PB portion is a little newer, but I do think over the last couple of years, they've really done a good job of building those checks out. So that's what we're working on now is again, within the context of centralizing to the functions, also working on the tools themselves or the technology.
That's great, Bobby. Thank you. And Shalondon just reminded me through her answer of how she sometimes knew my denials better than I did and helped me fix a whole lot of things in the revenue cycle. So I missed that. That's great. Okay, so I've taken a lot of these lovely folks' time for questions, but I want to give the crowd some time if you want to ask any of this wonderful panel any questions. So does anybody in the crowd have a question? Otherwise, I can keep going with mine. Yeah. I want to repeat the question for Bobby, if that's okay. So with regards to population health management, how, if at all, do you see it impacting your world and your daily workflows?
So for the population health model, I've worked with it before, so I think eventually it'll become a status quo. So oftentimes we're doing the things that population health is trying to implement. So we're doing them in our day-to-day. They're just putting a name to it, like some of the, I draw a blank, some of the coding nuances are like the going home with the patients and stuff like that. Those are things that are in the realm of coding that maybe we weren't billing for before, and now we're just seeing through population health that there's an opportunity for revenue that you're already doing that you hadn't done before. So through analytics, we're saying, hey, you do this many times. You know there's a code for that, and you can build that. So I think to your question is that it's new. It's kind of like COVID has peeled the cap off some things, and so we see it, and now it's going to become something that they pick up, and we'll just start billing for, and it'll eventually be streamlined, like the monitors for the halters and all that stuff like that. Transitional care, we're already doing that type of stuff. So the home health nurses are already calling. They're already doing the things that are like the checks and balances for you to be able to bill. They just were never billing it before, and I went to a meeting. I was like, that's some money, and they're like, what? And so it'll become the norm when they understand it.
I think it depends too on the geographic region that you're in. Sometimes population health and value-based care doesn't always work depending on what your structure looks like, what your reimbursement would be, and what your hospital services and provider services, how they integrate with each other.
I don't know how much of that you can do from a children's hospital perspective. I'm guessing it's a little harder because kids are sick or not sick. Is that kind of an accurate assessment?
Yeah, that's fair. And I was going to defer on this one and just candidly say I don't have a lot of experience here. So
that's fair. That's fair. Great question. Anyway, oh yes, Bill.
Curious what role each of you are playing in your organizations to hold the payers accountable for paying what they should pay, when they should pay. A lot of times your payer reps are not giving you the responses that you need and the time that you need them, and so to escalate some of what roles are y'all playing to try to make that more effective?
So the question is, what roles are you playing within your organization to hold payers accountable? And then I'm going to hand the mic over because I know people have passion about this one.
I no longer, I dealt with that formerly, but when you said that, you're making me smile bigger and bigger every time, because provider reps are not always helpful, or they don't know the answer and they don't know who to ask. So you consistently have to escalate to the next person, right? Well, guess what? That manager might not help you either because they don't want to pay for it. They don't want to do anything. the most effective thing, and this is terrible, and I'm not going to look because my boss is over there, so just kidding. One of the most effective ways, we had dental claims that weren't being paid for children that had specific needs to have their dentistry done in the hospital. And we actually worked with our CFO and the providers. There were 3 in the area. We sent them letters and we said, we are no longer going to allow you to do services here because that provider is not paying us. So we're done. You're going to have to go somewhere else. There's nowhere else for them to go. So the providers, or the physicians actually called it in, and I think it was 2 weeks later, everything started to get paid. So sometimes you have to you have to put it up to the top of your financial chain, get them involved, and start threatening something with the physician piece of it, because the providers don't, or the insurance companies don't listen until nobody, the physicians don't want to work with them anymore. It seems to be. No. No, of course not. No, it just was, they found something wrong, and then we reprocessed, and then they found something else wrong, and then we reprocessed. It was 2 years, 2 solid years of no payment from that payer. So your financial people start noticing that, and so they also get flagged for it, and they get passionate about it like I am, and I'm not even in charge of it anymore, so.
Yeah, so I would say that, I'm not in the coding and I'm not in the denials team. I don't manage the denials, but usually what happens is your reps start to see trends, and they say, I think you guys may be coding this wrong because we're not getting paid for it. And so just to give you an example, we had a run-in with Medicaid on critical care claims, and they were not paying our services. And our teams kept saying, you're coding these wrong, you're coding these wrong. And we had to go in and provide them with the documentation and with the coding guidelines on how to code critical care services. And Medicaid still would not pay us for the services. So we actually had to bring in legal. I mean, we were not afraid to kind of continue to fight. We brought in legal and got a judicial decision to say, Emory is coding the services right, you need to pay us. And so sometimes you have to continue to push and go as far as you can until you get the results that you're hoping for. And then there are cases where you don't. We're fighting Medicare now on critical care services and how we bill APPs. And sometimes you're not as successful, but sometimes you are. And so I would just say, don't stop at just the payer rep. Go as far as you can, even if you have to bring in legal. Absolutely.
Power in data and having that information. Whereas before it was we were paying okay, you were paying okay, but now there's a trend that you're not, and you're slow to pay or whatever. Just
Absolutely.
having that more than just saying it's happening, be specific and show what's happening.
Use your contracts.
Yeah.
Use your contracts and your interpretations of your contracts and send
Yep.
that right back, because they can't refute themselves.
Thank you.
And I would just add that we do have a department, and I recommend this, we do have a department that specifically looks at, are we getting paid according to our contract? So we have a team that looks at that to see if we're getting underpaid, and that helps drive some of those conversations as well.
Okay, so I know we're a little bit over because we started a little bit late. I'd like to say thank you to all of our wonderful panelists. I think it was an excellent and maybe the best panel of the entire conference. It's definitely the best one so far, right? Yes, wonderful. Please don't forget, shameless plug, to make a donation to the food bank if you feel so called, and also to stop by Alpha 2's booth and you'll see lovely Deanne. All right, thanks y'all.